Good evening, everyone. I'm presenting a fairly brief paper as part of your starters. This was published in the JBJS in this year. Is a fracture of the transverse process of L5, a predictor of pelvic fracture instability, published in Stoke-on-Trent in the University Hospital in North Staffordshire. So a little bit of background: unstable pelvic fractures still cause significant morbidity and mortality, reported to be around 10 to 20%, with hemorrhage being the commonest cause of mortality. And the mainstay of treatment is still EMST principles. Early recognition and management are essential to avoid any poor outcomes. And the increased use of pelvic binders may actually mask the detection of unstable injuries, as the paramedics are applying these quite prudently early on. So the aim of this study was do L5 transverse process fractures, are they an indicator of an unstable pelvic fracture, which will indicate a rupture of the anulolumbar ligament, which has its origin from the transverse process of L5 to the iliac crest. This has been well noticed in a lot of smaller studies, but actually, interestingly, it's never been published to date, and they wanted to publish this to verify these findings. So what they did a single center prospective data collection from their trauma database over a 4-year period. Did a fairly simple data collection of demographics, mechanism of injury, and fracture classification. They used the Young and Burgess classification. Looked at associated injuries and whether there's any surgical intervention. Fairly busy slide, but this is the Young and Burgess classification of pelvic fractures. So there are A, B, and C are the anterior posterior compression types. 1 and 2 are stable. Type C and D and E and F are unstable, as is vertical shear. So they had 80 patients in total, 48 males, 32 females, with a mean age of 40. Interestingly, they included pediatric population. There was a 10-year-old in there. And the vast majority were of mechanisms of injury were from motor vehicle accidents and fall from heights, which made up 58 patients. The commonest associated injuries were long bone fractures, chest injuries, and acetabular fractures, as well as head, spine, and intra-abdominal injuries. So they did a table looking at the stable fractures, which numbered 45, and the unstable fractures, which were 35 in total. Of these, 42 in the stable group had no L5 transverse process fracture, and only 3 had a transverse process fracture. And in the unstable group, 21 patients had no L5 transverse process fracture, whereas 14 had a transverse process fracture, and this was deemed to be statistically significant. They had 4 deaths. One of these, only 1 patient had a L5 transverse process fracture. There's no actual, they haven't given us details on what the cause of death were in any of the deaths. They just said they died from other injuries. Interestingly, in this cohort, 12% of the patients had an intra-abdominal injury, which was 2 out of the 17 patients who had a transverse process injury. So the statistical analysis, they used the chi-squared test with a p-value less than 0.05. 17 transverse process fractures, like I said, in 80 patients. 14 of these, 40%, were unstable, and only 7% occurred in the stable fracture group, which was statistically significant, 0.01. And the odds ratios was 9.3, and the relative risk was 2.3. So really the discussion and the main findings were that L5 transverse process fractures do actually indicate an increased risk of unstable pelvic fracture. I don't know why that's a mistake. So they used the analogy of the pelvic ring stability, like a suspension bridge where the posterior elements are the most important. So they regard the iliac crest as being the sort of pillars, the posterior sacroiliac ligaments as being the sort of the suspensory elements, and the sacrum, the bridge. And any avulsion or shear fracture of the transverse process fracture of L5 will indicate an iliolumbar ligament injury, which would mean that the fracture is more unstable. In terms of critique of the paper, the strengths of it, I suppose, is new evidence. It's never been published before, and it's an important diagnostic relationship that you must look for. It was a prospective single centre with reasonably good numbers, and did include both the paediatric and adult populations. However, there's no mention that they got ethical approval, and they don't mention what type of imaging modality they used, whether they used just plain X-rays as part of your EMST trauma protocol, or whether they use CT scanning. It's not documented. Although they mention surgical fixation, they don't mention, what type they used and in which patients. And there's no clinical, radiological, or patient outcome data. This is purely a L5 transverse process fracture, was it present or not, study, which seems a fairly basic thing to do. And that's really all there is to say. It's a fairly brief paper.
Thanks, Brad. That's a really good association. I mean, all the ones we've done trauma at the trauma hospitals, we often see it, but I never thought of that association. We just went on to get a CT scan of the pelvis to see it was unstable, but it's quite an impressive association.
No, when I grew up, I didn't think there wasn't an association. It would be an isolated injury.
I've never read it in my. Did you know about that, Anna? I think that's the same exam.
Yeah, so you've always understood an association.
Anyone else here knew that association?
Not L5, but maybe L4 and higher, you come and think of L4. And then you think of what else, maybe disk space or maybe intra-abdominal. Those things would kind of off my head with that, but not. Anatomically, it's more like a in between the lumbar stability above and the lumbar sacral and above, and it's just hanging in there, and it could go either way.
I mean, it's a pretty important thing in the future. It might be like the spine fracture that, when you see that, you think of something. That ends up being true. It's a pretty impressive paper to make that association. No, it's just a risk factor, isn't it? Yeah. I think it's important teaching, because if you get a ED registrar down, there's a pelvic injury, and they know L5 may be unstable pelvis, it could have repercussions, but yeah, not an correlation.
You would normally not statistically.
I don't need to do that anymore, Richard. That's why I'm around to you. I'm feeling over my man. No, we're doing, Narelle and I are doing some things together. She's, sorry? Above board, basically.
The relevance of this paper, like in the trauma series, they will do a pelvic fracture anyway. In the clinical settings, I mean, it's what they're saying that if you got a transverse process fracture, you've just got to be aware that it might be a higher likelihood of an unstable pelvis. But when you get a trauma series X-ray, you will always pick if there's anything of that nature.
I think their point was that you because in their centre the pelvic binders come on so quickly, you won't be assessing their stability clinically. But if you have a L5 fracture, then you know that you'll have to be perhaps prepared for increased blood loss, high volume blood loss in a rapid pace, so you need to be more prepared. Maybe.
Yeah, I think that's right. But I'm saying that in case of that, it probably is not a main criteria. But if you have missed something subtle and you see a L5 transverse cost fracture, you may probably screen it more because there is an L5 transverse cost fracture.
What's the other one that comes to mind in that same sort of connection?
Pelvic fractures.
No, you see a fracture somewhere and you think immediately you've got to look somewhere else. Yeah, that's right. Calcaneus and a lung fracture. That's what I remember.
Where was that, right?
You know, you see a calcaneal fracture, calcaneal fracture from the bottom, immediately you've got to check it.
Probably useful. I mean, not infrequently you someone from the country or from a small city where there's a trauma centre often call you and say, I've got someone who's fallen off the stairs and has a fractured pelvis. Do you think it's right just to rest it in hospital for 3 weeks or whatever? I mean, it's a question you could ask, isn't it? Yeah. And of course, you would just say, well,
The difficulty with isolating something like this, so you've got an L5 transverse process fracture, so you might have an unstable pelvis. Is that if you've got the binder on, how if it open books when you take the binder off and you are in a rural area, like what are you supposed to tell them to do? Because the teaching is that you're not supposed to leave the binder on for too long because it can cause pressure necrosis in itself and other problems. So I suppose that kind of means that they might have to look for a trauma centre sooner, I suppose.
We've seen something that has required a binder by
Actually, it's not anyway.
Yeah. True.